The patient is a 76-year-old woman who presents with a left hemispheric stroke. She was treated with intravenous tissue plasminogen activator based upon initial imaging. She had some mild initial improvement but then deteriorated again. The MRI showed diffusion changes in the left middle cerebral artery distribution. Subsequent angiographic evaluation demonstrated occlusion of the middle cerebral artery with moya-moya-type changes. The patient had a watershed ischemic type of injury with some additional injury to the posterior division of the middle cerebral artery on the dominant side. She was treated with maximal medical therapy, including blood pressure elevation and hyperdynamic hypervolemic therapy. Unfortunately, the patient subsequently developed further worsening of her clinical picture with associated new changes on the MRI, and a meeting was held with the family to discuss the option of urgent cerebral revascularization. Options, risks, and potential complications of this relatively aggressive procedure, given the patient's age, were fully discussed. Nevertheless, there was a fair amount of middle cerebral territory left at risk, and this was confirmed on perfusion CT. The family understood and asked that we proceed. Description of operation. The patient was brought to the operating room. General anesthesia was induced without difficulty. Hypotension or hyperventilation were avoided. The course of the superficial temporal artery was mapped out with a Doppler. Shaving of a strip of hair along the panned incision line done, the patient secured in the radiolucent head frame, and she was prepped and draped in a sterile fashion. Proceeded to make a gently curving incision beginning in front of the left ear at the level of the zygoma and coming up anteriorly to the hairline. The operating microscope was brought into the field, and the root of the left superficial temporal artery was identified. The anterior branch was much larger than the parietal branch. Carefully dissection out a long length of the anterior branch without difficulty. Small side branches were coagulated and divided. The temporalis fossa and muscle were reflected inferiorly, and a temporal craniotomy was performed centered at the squamosal suture. Identification of a large cortical middle cerebral branch that appeared to be a nice-sized match for the donor vessel. Arachnoid was taken down. Small side branches were coagulated and divided. At this point, the superficial temporal artery was temporarily occluded, proximally and distally ligated, and a fishmouth opening created. It was irrigated with heparinized saline solution. The cortical middle cerebral branch was trapped between low-tension aneurysm clips. The anastomosis was performed with 10-0 suture. Clips were removed, and there was good flow with an excellent pulse in this nice long flat anastomosis. The procedure was complicated by the fact that the brain itself was somewhat full, based on the recent stroke. Nevertheless, a very nice bypass was obtained for the patient. At this point, meticulous hemostasis was achieved. The dura was reapproximated. The bone flap was replaced with titanium plates and screws. The scalp was closed in layers. A sterile dressing was applied. The patient was returned to the recovery room, where she awoke in satisfactory condition. The postoperative CT scan looked stable. The CT scan 2 weeks after the bypass continued to show stability, and the patient was able to leave the acute neurorehabilitation.